Welcome to the Path to Recovery, understanding the ups and downs of addiction treatment. My name is Merlene Tucker, and I'll be running today's web forum along with my colleague Jeff Bornstein. This web forum is sponsored by the National Overdose Prevention Network and produced by Dialogue for Health, both programs of PHI Center for Health, Leadership, and Impact. The support for this webinar series was made possible through the funding from the California Healthcare Foundation. Now let's meet the moderator of today's event, Dr. Carmen Rita Nevarez. Carmen is a senior advisor at PHI Center for Health, Leadership, and Impact, founder of Dialogue for Health, and senior vice president emeritus of External Relations and Preventive Medicine at the Public Health Institute. Welcome, Carmen.
Good morning, everybody, or actually good afternoon. I am really pleased to see so many of you with us and to note that we have over 600 people registered for this webinar. So we are hoping that there'll be a larger audience growing in the next few minutes. We take that over 600 folks from across the country. We take that as a sign that people are deeply interested in this issue and want to keep pursuing their knowledge and really enlarging their perspective on the issue. Substance use and its consequences are problems that face far too many of our families, our workplaces, and our communities. The overdose deaths have skyrocketed to way over 100,000 a year. That's equivalent to the entire population of Lansing, Michigan, Pueblo, Colorado, Green Bay, Wisconsin, or Carmel, California. Nearly a third of all adults in the U.S. know of someone who has died from an accidental drug poisoning. But there's hope. The purpose of this webinar is to help us learn more about addiction and the many paths to recovery, and to think more deeply about what we can do as a society to recognize the problem before it becomes lethal and help people to get the care they need so they can join the millions of people who are in recovery. See the next slide, please. First, let me tell you a little bit about Center for Health Leadership and Impact, who's sponsoring this webinar series. We are a public health do tank that helps individuals and teams to transform their vision into data-driven strategies. By cultivating leadership, catalyzing learning networks, and strengthening cross-sector partnerships, we help to create equitable, lasting impact in communities. Since 1991, almost 8,000 leaders in 53 states and territories have applied our tools and processes to address a wide range of issues, including overdose prevention. Next slide, please. The National Overdose Prevention Network is one of our standout programs that is free to join, available to the public, and can benefit you and your community by supporting you to develop strategies and best practices that engage all of your assets and partners. NOPEN shares policy ideas and wins and supports your network to be sustainable over time. Next. So I hope by the end of this webinar that you see some opportunities here and that you will join the NOPEN to connect to more learning opportunities, more resources, and a large community that's deeply concerned and committed to stopping preventable deaths due to substance use. Next, please. So throughout today's session, I'll encourage you to post your reactions, your questions, and your comments in our Q&A section. You find that by just looking at the bottom bar of your Zoom screen. After we hear from our two speakers, we'll have some time to address the issues that you've raised. So I encourage you all to comment. I encourage you to give us your reactions and absolutely give us your questions or your stories. And we'll do our best to get it all, weave it into our larger story that we're trying to create here today. Next. So today's learning objectives will help you to be able to describe how substance use disorder treatment works in practice, including the critical importance of the continuum of care from initial diagnosis through ongoing recovery. You'll be able to identify multiple access points for treatment, including emergency departments, outpatient clinics, and inpatient treatment facilities. And you'll have a chance to explore some practical strategies to reduce stigma, increase awareness, and support more compassionate informed, and accessible pathways to treatment and recovery. I want to start by extending a very, very warm welcome to our first presenter, Xenia Cardosa. Ms. Cardosa has been working in the addiction treatment field for nearly 18 years, primarily in Santa Clara County, after entering recovery nearly 20 years ago. Xenia works as a substance use navigator, or SUN, in the emergency department, a role that was started in partnership with the California Bridge program. Xenia's work has paved the way for Stanford University Hospital's emergency department to provide low barrier access to medication assisted treatment, MAT, real-time linkage to substance use treatment programs, and harm reduction interventions such as take-home naloxone. For her work as a strong advocate for improving care for individuals living with substance use disorders, she was awarded the CD Roll Outpatient Counselor for professionalism by the Alcohol and Drug Studies Advisory Board at San Jose City College in 2018, and the Community Hero Award by Santa Clara County Behavioral Health Board in 2022. So I welcome you, and I'd like you to go ahead and take the mic, Xenia.
Thank you. I wanted to share about my recovery journey when it was a lot different nearly 20 years ago, and I'm glad that we're moving in a different direction. But I can share that around the time I started noticing that there was something going on and I needed help. The prior generation in my family was already in recovery, so I had that support. I did start going to services, to outpatients, but I continued to use despite the treatment. So back then, if you started using, you were discharged. There was never talk of changing levels of care, but family started sending, maybe you need to go to residential. I would go to residential. I wouldn't be able to stay. I didn't know what I needed. I know I wanted to stop, but I didn't know what I needed. I didn't know that the program needed to be adjusted. What I was told and what I was shown was that somehow it was me failing the programs over and over again. But after about 7 or 8 different attempts of me trying to figure out what it was that I needed, I found out that I needed a bunch of different pieces to work together. But so in the beginning, there was, I had like commercial insurance and whatnot, but as I got sicker and ended up not being able to work and ended up in being unhoused for several years, it seemed like the services got less and less and more disconnected. So if I needed the pieces to work together, it was going to take a lot of work to get them working for me. With the biggest barriers that I had was if I needed attention or help in an area, it was that there was a 6-week wait list or there was no appointments available. And in the moment when I was dealing with what the symptoms I was dealing with, I needed help now. And the frustrating part was that I didn't have an access point that really worked. I found out in the end that I needed a lock stay, which isn't readily available, especially for those on Medicaid. But my lock stay became incarceration. That was the only detox center that worked for me. And then from there, I would transition out into the different services that were available. And hopefully they were able to work together in order for me to stay clean for a while. So eventually I got all the pieces together and I've been able to stay 19 years now, but it did take a lot of times of feeling the disappointment and blame and unworthiness and thinking that it was something that was going wrong with me, or it was lack of willingness, or I didn't want to change. And that was absolutely not the truth. It was always, I did want to change. I just didn't know how many pieces needed to fit together. And then when I did figure out what the pieces were, then trying to navigate and try to make all those pieces work together at the same time so I could be stable enough. So sharing now how that transitions into my role as a navigator, developing this role in the emergency department, creating the emergency department with California Bridge to become an access point has been amazing. It's going out and talking to all the different providers. Emails and virtual calls don't work. I found that in this field, relationships and personal connections work, and having that. If a person is a veteran, then we have a contact at the VA. If there's a person at this county or at that county, and it's going out to all those different places and building those relationships so that when someone asks for help and they need help now, that we're able to do it the best we can. So far, we've been becoming really successful at helping people get the services that they need when they ask for them when they're now. There's a lot of more people asking for help and wanting to change than there is not. So my focus is on the people that say, I don't know what I need to do, but I'm willing to try. And we start the relationship and collaboration and said, hey, we may have, setbacks and stuff, but I'm here with you and I'm here for it. And we continue to support them, whatever that path looks like. So thanks for letting me share.
Zenny, I want to thank you for that. I think that you'll have a chance to talk a little bit more as we get into this conversation, but it matters so much to hear from somebody who has actually walked in the shoes of somebody seeking, trying to find, trying to connect with, trying to stay with treatment. No matter what kind of work you do, if you don't know who the people are that you're trying to work for, it just you can't do very good work. And so I really welcome you to this conversation, and I know you'll bring so much to to where we go. And then also in the audience, I know there are people out there who might have had similar experience, and if you want to post any of that, please do. It really helps to enrich our conversation and help us to be much more compassionate and much more open to understanding the kinds of issues that people have to struggle with in order to get where they need to be. So I'm going to transition us a little bit to our second speaker, because we want to hear a little bit from somebody who works on the side of providing care as a clinician, and to also, one of the special things about our speaker here, our second speaker, is that he's worked nationally to try to develop the best possible systems that we can have in order to really configure our resources in a way that makes sense, in a way that is flexible, and in a way that has proven results. So let me welcome our Dr. Brian Hurley, who is a physician specializing in addiction and is the medical director of the Division of Substance Abuse Prevention and Control for Los Angeles County Department of Public Health. Dr. Hurley currently serves as the president of the American Society for Addiction Medicine, which is also called ASAM, for their board of directors, a national organization of more than 8,000 physicians, clinicians, and related professionals who specialize in addiction medicine. He chairs the Los Angeles County Safe Med LA Medications for Addiction Treatment Action Team, and is the clinical director of the Addiction Treatment Starts Here programs through the Center for Care Innovations, focused on increasing the delivery of medications for addiction treatment in California's community health centers. He's also a senior researcher at the Friends Research Institute and is the grant lead for several medications for addiction treatment access points projects funded by the Sierra Health Foundation, and supporting access to medications for addiction treatment across Los Angeles County. So with that overview, I want to welcome Dr. Brian Hurley to the stage and ask him to tell us, take us down a path of understanding where we can go.
Sure. Hey, thank you so much for having me. As mentioned, I'm Brian. I'm an addiction physician based in Los Angeles. And I think one of the things that Xenia's story really emphasized to me is that we have a history of delivering substance use treatment that is program-centered. So if you ever hear of a treatment program saying things like, we're a 28-day program, we're a 60-day program, or a 90-day program? Well, I'll ask, how many days of treatment do you think somebody gets in a 28-day program? Somewhere close to 28 unless they leave, right? Or how many days of treatment do you think is offered in a 60-day program? Somewhere close to 60 unless somebody takes off, right? And that sort of thinking, which is what's the right program, totally overlooks the key question, which is what is the right amount of treatment? And the truth is, it's the treatment the patient needs. And for some people, it's shorter. For some people, it's longer. Addiction is a lifelong illness, which means that people come into and out of needing different supports at different periods of time in their lives. But again, we sort of have this history of trying to put people in boxes, and it turns out people are not boxed shaped. We need to be patient-centered or person-centered in the way that we deliver treatment and do our best to get treatment to people. So that is what I'm going to be talking about. In reading my bio, I'm now the immediate past president of ASAM, the American Society of Addiction Medicine. ASAM has actually a standard. It's called the ASAM criteria. It sets the national standards for the treatment of addiction. So if the question is, okay, care should be person-centered, well, what is the framework for doing that? I would point you to the ASAM criteria, and obviously I'm not unbiased with respect to ASAM. All right, so with that, no financial conflicts, but like I am on the board of ASAM and I'm not like neutral with respect to ASAM. I want to talk about the definition of addiction. This comes actually from ASAM. Addiction is defined as a treatable chronic medical disease that involves the brain, genetics, the environment, and somebody's life experiences. And it manifests as the use of substances or engagement in the behaviors that oftentimes become compulsive and continue despite harm. Now, that said, there are a lot of chronic illnesses that involve the brain, that involve behavior. I think of people with congestive heart failure that typically also have behavior-based drivers of chronic heart conditions. And it turns out like prevention and treatment work about as well for addiction as they work for other things. We don't think about it that way, but that's what I'm going to be emphasizing over the course of our time together. Addiction is based in the brain, and it's conceptualized again as a chronic brain disease. There's a number of different structures, but you sort of think of the cycle of addiction as people use, and then whenever what they use wears off, they feel worse. And so that then generates preoccupation. If you do this enough, you tend to develop a use disorder or an addiction. And it can be to substances, it can be to behaviors, but this is kind of the cycle of addiction. Again, it's based on the way the brain works. The non-addicted brain, generally speaking, even if somebody, say, consumes alcohol or uses a tobacco product, they might have that experience, but the frontal lobe that helps, well, make reasoned decisions, right? What are the risks, benefits, and alternatives to any given course of condition, any given course of action? The addicted brain has like the subconscious part that drives substance use tends to override that frontal lobe. And so you'll hear people with substance users saying, I didn't even think about it. Like I walked past that bar, I walked past that street corner, I was near the people, places, and things where I was using before, and I wasn't even thinking about using. I just found myself using. And that's not an unusual experience for people. That is to say, addiction is a disease where people have like diminished self-control. It doesn't mean people can't make decisions or can't make reasoned decisions, but it means that people's kind of innate capacity to say, you know what, I have something to do later today or early tomorrow. I'm not going to have that drink. I'm not going to go smoke that thing. I'm not going to use that substance. That voice is sort of turned down. It's not off, but that voice is turned down. So that's one way to sort of think about the disease of addiction. Now, I've talked about the definition and how the disease works in the brain. There's actually a diagnostic criteria. There's 11 diagnostic criteria. It's in a book called the DSM. And I don't think it's easy to remember all 11 criteria, but I think you can cluster them in 3. I call them the 3 C's. If somebody's demonstrating that they're, finding difficulty self-controlling their substance use, they're using more than they intend, they're trying to cut down, but they're having a tough time, they're experiencing cravings, and that kind of loosely is tolerance and withdrawal included under cravings, and consequences, right? Harm related to their substance use. if you're noticing this cluster of people losing control, having a lot of cravings, and experiencing consequences, somebody probably has addictive disease. Now, this implies that if you use a substance, you're going to develop an addiction to that substance, and that's actually not true. There's individual variability. Not everyone gets addicted to everything. Cannabis. People that use cannabis over the course of their lives have roughly a 9% rate of developing addiction over one's lifetime, right? It's not at any given moment. It's, cumulatively over one's lifetime, if you use a cannabis product, about 9% chance that you'll develop an addiction, which means two things. Most people who use cannabis will never develop addiction to cannabis. And cannabis is also addictive, right? Like it's not an unaddictive or, has absolutely no addiction risk. Cocaine, which we think is very addictive, has a roughly 21% lifetime risk. Alcohol is about 23%, and tobacco is like 2/3 of people who use tobacco products. And you'll notice, what do alcohol and tobacco have in common? The cannabis, when the NESARC, which was the study this was based on, was going on. Well, alcohol and tobacco are legal and marketed, and cannabis and cocaine aren't, which means it's not just the biology. It's the way people use substances. And is it socially reinforced? And is it common, right? The way the social the extent of the availability and social acceptability of substances makes them more addictive, right? It's not purely biologic, right? It's the interaction of our biology with the environment we're in. So one big treatment for addiction that many people are aware of is community self-help. Surround yourself with people who aren't using, right? That are able to get through their day. They go to meetings, then they hang afterwards. Like, you learn how to get through your time without drinking, without smoking, without using other substances. Opioids, the NESARC, which is the study that looked at this, they didn't look at opioids specifically, and the addictivity, that's a word, of opioids ranges between 3% of people with opioids to 30% of people with opioids develop an opioid use disorder. It really depends on the group we're looking at, right? So people that take opioids regularly, and we can look back to the 90s and 2000s, for what happens when people are prescribed chronic opioids, we saw pretty high rates of opioid use disorder. It wasn't the majority of folks, by the way, but we saw high rates, again, related to the availability and just the acceptability of using a substance. Okay, so this actually there's a report that came out on, like, what do we know about the development of any disease, and what do we know about people's health outcomes, right? And it turns out health outcomes are impacted by behaviors and access to care. But the biggest driver of health outcomes is social and economic factors, right? That is the biggest kind of contributor to our health and well-being as individuals in the world, right? And so we see addiction happen in communities disproportionately impacted by social inequality, structural violence, and poverty, right? Now, that doesn't mean that addiction doesn't happen elsewhere. Addiction happens in every social strata, but it tends to be more concentrated, right? The rates are higher in people that don't have access to healthcare, have poor living conditions, have individual behaviors like alcohol and substance use and, social disconnection, and by the social and economic factors that affect our overall health. And so I just wanted to make the point, like, it's not just substance use, it's sort of substance use alongside the full context of people's health. And there's genetic risk factors. A lot of addiction is inherited, but also social influences. One of the biggest social drivers of vulnerability to STD is adverse childhood experiences. That is, what was people's structural stability growing up? So one thing about substance use prevention, which is something I work on here in LA, is how do you actually substance use prevention has almost nothing to do with substances and everything to do with how do you help kids develop normal, healthy lives where they can regulate their emotions with their best tool not being that thing you drink, thing you take, thing you smoke, right? That to me is key substance use prevention actually is healthy childhood development, where you help people avoid developing the adverse childhood experiences that drive substance use in the first place. So these are kind of what we think about, but there are still genetic, it's not all environmental, it's not all biological, right? It's sort of the combination of genetics, the environment, and how people develop in the world. And I just want to point out, like, there is a fair amount of genetic heritability. I want to thank my colleague, Dr. Sepulveda, for lending me this slide, right? You can look at twin studies that seem to account for between a half and 3/4 of the risk for addiction. And genetic factors really appear to be even stronger than environmental factors, particularly for people that begin using substances early in their lives. Now, addiction, I've mentioned this a couple times, a chronic brain disease. We see this in other conditions like Alzheimer's and schizophrenia and substance use disorders. And these are brain conditions, again, that impact biological structures, the way our brain works, and the functioning of our organs. So this is kind of putting it all together, right? Like there's genetics, there's the social determinants of health, plus substance use, plus like other risk factors generates that cycle that I mentioned earlier, right? Using, feeling worse, using again, right? So that's, and this actually comes from New England Journal of Medicine and from the Facing Addiction in America Surgeon General report. So what do we do within the context of people that are using substances? And when people use substances, people and their relationship to substances exists in all kinds of dimensions, right? So one is like, how ready is somebody to make a change in their substance use? And you'll notice I say change in substance use, because if I ask somebody I'm working with the question, are you ready to commit to never using alcohol, tobacco, cannabis, caffeine, or any other intoxicant forever for the rest of your life? And they say, no, 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 I'm not ready to do that. That to me obscures meaningful information over things like, well, I might be ready to stop injecting something if you gave me a medicine so I don't get sick when I stop injecting. Or, but I'm not ready to stop smoking, right? Or I'm ready to stop using fentanyl and methamphetamine, but like I'm not going to give up the cannabis and the tobacco, right? Like those are nuanced and important conversations. But understand, like people are in variable stages of change kind of throughout their lives, right? And people come into and out of commitment for abstinence or commitment to other things. And that is normal. That is a normal, like, I don't know how many of you do every single thing that your doctor tells you to do, but I would just ask you if you've ever like not followed instructions, like you might identify with this, right? Like people, we go into and out of readiness all the time. And so it's really important. And again, I work for health department. How do I build systems so where people can get outreach and connection and to support and low threshold medication treatments, regardless of whether they're ready to stop using, right? Like risk reduction programs. Everyone has access to naloxone, test strips, outreach, connections to housing. No questions asked, not predicated on a commitment to change. And then like change-oriented programs, right? Biopsychosocial programs involving meds, counseling, and support designed to support people making changes, right? Now, I will say, we sort of think, like I've talked about addiction as a chronic brain condition, and it is. But I also say if you look at people over the course of their lifetime, about 75% of people with a substance use disorder go into remission. Recovery is possible. So I think of like the substance use disorder as sort of what somebody goes through a period of time in their lives. But treatment really does help people support people remission. The key from my perspective is how do you keep people alive and engaged and supported throughout their stages of change? And that prioritizes connection over compliance. Right, I'm much more interested in how do you find out somebody's ideas and values and intentions and align services with them rather than, well, you weren't ready to go to our 20-day program, so call me when you're ready, which is a very disconnecting move to make. You might have heard the term meet people where they are. That has been a mantra of mine. I've also started to adjust the term align services with readiness, right? Find the thing that the person is aligned with and work on that as the foundation. What we're really offering people is connection. And, you know, in the United States, there's a very long history of criminalizing people to use drugs, criminalizing drugs. I think one of the things about Xenia's story that stuck out was it was easier. I'm paraphrasing here, but like the lock setting for me was incarceration. It wasn't treatment. You know what I mean? Like we've built a system where incarceration is oftentimes the thing that people are pushed to. And just to be clear, incarceration increases the risk of death for people with addiction by like over 8-fold. It is a huge driver of overdose mortality is incarcerating people. Okay. We tend to have selective forgiveness and understanding, right? So if somebody has diabetes, we don't say, well, we're not going to treat your diabetes until you get your blood sugar under control. We don't tell people with high blood pressure, we're not going to treat your high blood pressure until your blood pressure comes down. But we do this with addiction all the time. We say, like, call us when you're ready, and then we'll help you stop using. You know what I mean? So there's this like sort of selectivity and forgiveness and understanding. What I'm really speaking about is stigma, right? There's a lot of stigma. But the problem with like talking about stigma, from my perspective, is that talking about stigma is sort of like talking about like, I don't like, any other broad, like social headwind, right? But okay, like if you don't like stigma, what do you do? So one, I talk about a return to symptoms as opposed to relapse. That tends to be, I think, relapse and recovery are both part of the R's, but it's sort of like, well, I return to symptoms. And the truth is, the percentage of people who return to use with substance use is about the same as the amount of people who have hemoglobin A1Cs, which is a blood sugar measure, right? Have high blood sugar, they have hypertension under treatment, or have high blood pressure, even though their blood pressure is under treatment, or have, asthma, even though their asthma is under treatment. Like people come into and out of remission all the time. That is true, just as true with substance use disorders. And I mentioned care should be person-centered. This is a snapshot of the 4th edition of the ASAM criteria that defines the standards for hospital, residential, high-intensity outpatient, and early intervention services. But like so few people seek treatment. Like truly, so few people seek treatment. When I say so few people, about 19% of people with an SUD receive treatment, any sort of treatment. And this is like a national data from the National Survey on Drug Use and Health, right? So very few people seek treatment. If we say, well, who actually makes it to a treatment program, like a, federally designated licensed specialty STD program, it's somewhere around 6%, right? So most people get treatment, get it actually outside of the specialty system. But whether we're talking about a treatment gap of 80% or 95%, like the vast majority of people don't seek treatment. And one of the big reasons is they don't want it. Or how do I put this? People they're not necessarily interested in like going to a high threshold treatment system, right? Now, why wouldn't want somebody to go to a high threshold treatment system? They're worried that they can't afford it. They're worried that there might not be, what would people think? I should be able to handle this on my own. There's a lot of kind of information and just ideas that like there's a whole set of requirements you have to do to be ready for treatment. But we still have access issues. Like there's still people that try to go and can't get in, right? So we still have access issues in our substance use system. But the biggest driver of the treatment gap isn't actually lack of supply, it's lack of demand. But I look at this question slightly differently, which is I don't think we're going to be successful by like simply opening up more treatment slots, like more residential beds or high intensity outpatient beds or OTP slots, without also trying to get the care that we deliver in those facilities out to where people are. And look no further than California Bridge is a good example of that, right? California Bridge is on no questions asked. Let's treat you opioid withdrawal. Let's get you started on treatment for opioid disorder. Let's get you navigated. You know what I mean? Like it doesn't matter what your insurance is. It doesn't like we will help you. We will find a way to make this happen, right? And that is a great example of like bringing treatment to people rather than expecting people to call a number, get a scheduled admission, and go to a treatment program. It brings treatment to people. And there are so many other examples of that in primary care, community mental health care, street medicine care, carceral care. Like there are a whole number of examples of trying to get treatment to people rather than expecting people to go to treatment. And the Surgeon General agrees with me, right? So the quote from the Facing Addiction in America is integrating substance use services results in better outcomes. So, stigma. It's an identifying marker characteristic that indicates the presence of a disease. That's from Merriam-Webster. And I'd say, like, if you really want to work on stigma, work on your language. Like, what the words we use shape how we think, and how we think shapes how we act. So I think less around like stigma, which is a broad thing, and I think a lot about what are the words that I'm using. Because I, as a physician, think of myself as ethically bound to provide services that give people the best chance of success. And I've heard like nonsensical things. Like I don't believe in buprenorphine. I'm a naltrexone person. And it's sort of like saying I don't really believe in insulin. I'm like a diabetes and insulin. Like it's sort of like insulin works regardless of it's not faith-based. You know what I mean? Like it is an effective treatment for diabetes. You know what I mean? Like it doesn't require so but we sort of apply that like I don't know, faith-based framework to what there's actually a fair amount of evidence about. So just to be really clear, addiction medications are the gold standard for opioid use disorder, like the gold standard, like methadone, buprenorphine, naltrexone, gold standard treatments for opioid use disorder. Just to be like really, really explicit about it. But there's other terms that we use all the time that I try to be very thoughtful about. So I don't use the term clean and sober to refer to people, because if somebody is abstinent, and they say, "Oh, I've been clean," and somebody isn't abstinent, what would be the other word you would use? And I don't think that the word that I'm thinking of is a neutral term. It's a pejorative term, right? So the language, how we talk about addiction matters. And there's actually this like go no-go study, that actually assess like implicit biases. So when we say words like drug addict, she can't seem to get clean, our community has a drug abuse problem, she can't seem to avoid relapse, the patient had a dirty urine. Well, I'll even ask, like, is urine ever really clean? Like even under the best of circumstances, is urine ever really clean? The truth is, like, urines are positive or negative for certain substances, and that is neutral. That I use that term very neutrally. If I'm prescribing somebody buprenorphine and their urine is negative for buprenorphine, that triggers a conversation. Huh, that's so interesting. Let's talk about that, right? That's a pertinent negative. And if somebody is taking, methadone and the urine's positive for methadone, that's an expected positive, right? So like I don't think about these things in terms of black or white. Like we're patient-centered or person-centered in the way that we do this. So I mentioned this no-go tasks. Terms to think about is like substance abuser or substance abuser are not great terms. Relapse. Medication-assisted treatment is a really weird word. Like what is is it? So if med is assisting treatment, then the med's not treating something. So like I use the word meds, pharmacotherapy or addiction pharmacotherapy, rather than medication-assisted treatment, just because it's kind of like we don't talk about antidepressants as medication-assisted cognitive behavioral therapy, or like metformin as medication-assisted diet and exercise. Like those are treatments for depression or for diabetes. I noticed Dr. Navarez used the term poisoning as opposed to overdose, right? So that is sort of another example of a term. Addict, alcoholic, opioid addict, those are all terms that generally make people think this person should be punished as opposed to this person should be helped. So think about this person uses substances, recurrence of use, abstinence. I use the word remission, pharmacotherapy, accidental drug poisoning, person with a substance use disorder. Like those are all relatively neutral terms that help ground me and what would be helpful and best for them, as opposed to like some like character flaw, which is oftentimes what gets a vote when negative terms are used. So spoiler alert, back in 2010, does our choice of substance use term influence perceptions? Yes. The term substance abuser is like more likely to benefit from punishment, more likely to be threatening, less likely to benefit from treatment. So alternatives, like my friend is a person that uses substances. She can't seem to abstain from them, or she can't seem to get into remission. Our community has a serious substance use problem. He can't seem to avoid recurrence of use would be alternatives. There's a whole training on this on the National Institute of Health website. NIDA, the National Drug Abuse, has a whole like language matters section, so feel free to refer to this for more information. So I think that wraps up my comments here today. This is my email address if you have any questions. And if you're like, hey, this is great, I want like a lot more of this, come to the addiction medicine meeting. Again, I'm not unbiased with respect to ASAP. Come to the addiction medicine meeting. It'll be in San Diego this April. Later on in the year, CSAM, the state chapter, has a wonderful state meeting out in August, and the addiction psychiatry meeting is going to be in Memphis this coming November. So with that, I think I turn it back to Dr. Navarez, I believe.
Thank you. Thank you, Brian. Thank you, Xenia. I think both of you gave a pretty robust set of images for all of us to be thinking about as we try to continually improve our way of being effective with our communities. There's a lot of questions that we're getting from the audience, and I want to just go ahead and dive into them. And please, anybody in the audience, just go ahead and throw in your questions or your comments because it's so useful. Helps us understand to help prompt what the speakers are saying, but it also helps myself and the other staff that are working on this webinar series to know what you want to know more about. So we can keep building this, we can keep making this better and even more robust. So please do, questions. If we don't get to yours today, we'll do our best to get it to it in a future webinar. So one really interesting comment that came up earlier, Brian, I want to just ask you to talk a little bit about, words really do matter. And I'm wondering, when we talk about problems with substance use being a brain disease, does that come out as being stigmatizing to the people who are trying to seek treatment, or does that help us to understand better the end organ, the organ that is being the most impacted in the beginning? So how does it help us, or how could it hurt us? And is there any alternative framing that would work better?
The term brain disease has been used now for decades. Maya Salitz has an alternative framing, which is a developmental disorder. Like it's something somebody goes through for a period of time. That still kind of borrows the disease framework, but brain disease sounds permanent, whereas developmental thing that somebody goes through for a period of time, this sort of sounds less permanent. I'll say, regardless of which of those metaphors that you use, when I talk to people with addiction, I sort of start off by saying, I don't know of anybody with addiction that doesn't feel really awful about themselves. You know what I mean? And I just sort of say, I don't know anyone, and people are like, oh my God, some people start to cry. It sort of gives people permission. Yeah, there's a lot of shame around this. And I'll say, what I'm here to do with you is find solutions. And we know from science that there's actually a lot of things that can help support people's well-being and their function. And so I'm here to work with you to help find those solutions, and we'll do that together. And so I'm still borrowing meds and counseling. Those are parts of solutions, and those sort of are kind of brain disease-y in there. But I'm not like, you have a brain disease, I'm diagnosing you with it and you have to come to it. I don't really emphasize I'm making a diagnosis. I'm sort of like, hey, all that shame you're holding, I want to acknowledge that you're probably feeling that. And not that this will necessarily change anything, but you don't actually have to, I want to normalize it. Actually what you're experiencing is people go through this. I want to normalize this is what you're going through, whether it's alcohol use disorder, opioid use disorder, amphetamine use disorder, is what people go through, and we can work together to find solutions. And that's kind of how I actually talk about it with people.
That's very helpful. I wonder, Xenia, do you have any thoughts about that? Do you find when you're talking to people that they they shiver when they think about it, brain disease, or maybe they feel a little relieved that brain disease, we could do something about this? What are your thoughts?
I'm really in agreement with Brian. I mean, I hear a brain disease and it's it gives me something to work on. But the other part is that if I have to acknowledge I have a brain disease, how sick am I?
Mm-hmm.
But there is a relief in saying I'm sick and not a bad person, right?
Mm-hmm.
And, yes, I'm here again, and having somebody say, it's okay. You're here again. So is everybody else with a chronic illness. The person next to you is just dealing with a different condition than you, but we're all the same. Welcome, and a lot of that unworthiness and shame is what keeps people from seeking treatment. They don't want to feel like they failed again, and now they're being treated as such, right? A lot of the people in their life are already doing that for them. So having providers or a place to come to, or knowing that they're not going to get that kind of reception, say, oh, well, this didn't work. Well, let's try something else, right? We get the same conversation when we go to mental health providers, right? We don't know which medication is going to work, and we're going to have to go through a few cocktails to see which one works for you. And I'm here for it, and I hope you're here for it with me. And that collaboration means a totally different conversation than you better get it this time because then we know you really want it. That's a totally different conversation. We would never say that to someone trying to regulate their diabetes or their hypertension, or we would never take that kind of approach. So to have this collaborative saying, well, I don't know what's going to work for you, but I'm here to be with you in it while we figure it out together. I think that approach has been the best. And those are the people that I remember through my journey that made an impact on me, that's had that unconditional acceptance and accepted me as like, we're trying to figure this out.
Yeah, that I think those are very useful ways to look at it. And again, anybody in the audience, you have something else to add, please go ahead and just pile on in the Q&A. I'm going to go on to the next issue, which I thought was very interesting. Given that addiction is a disease that changes the brain, how can we best integrate agency into the process of addiction recovery?
So I mentioned like diminished impulse control, diminished relapse prevention ability. It's not gone. It's not as though people's brains are permanently broken. It's more like, hey, you're going through this. This is something that people go through. Let's find solutions, but recovery is possible. And I really do emphasize, like, you can have a full, wonderful life, and let's work on that together, as opposed to like people are broken. It's sort of like an injury. You know what I mean? Like people might have an injury a period of time, like you need to get treatment for that. And there may always be sort of a recovery process that people need to attend to. But I really do emphasize recovery is possible and that people can make decisions, right? And I sort of remind people like, yeah, it might be hard to turn down the use of, say, methamphetamine in a certain circumstance, but most people, like, if they're in court, aren't using methamphetamine. So clearly people can, like, self-regulate. Like, it's just a matter of sort of set and setting. And so I mentioned that, like, how can we build supports around to help support your recovery?
Yeah. Xenia, you want to add on that?
I agree. There is that agency piece, but also acknowledging that as this illness progresses, you will start losing that agency, and there does come a point where no matter how much you want to stop, the compulsion continues, and you need more help, and you need more support than what you used to. Right? A lot of times I hear, "Well, I didn't need all of this before." Yeah, well, returning to use makes it harder the next time you want to come back, right? So acknowledging that whatever may have worked in the past, but now that you've returned to use will be harder this time, kind of takes that piece of, you still have an agency, but you're at risk for losing it. This is an urgent condition that you need to address right now before you lose your agency completely, because the level of care may not be available by the time you do really need it.
I really appreciate Zena's mention of, oftentimes people like, I should just be able to do this myself, and have to remind people like, as more time goes on,
Mhm.
the amount of help you need might increase. You know what I mean? Like you might need to sort of something external to you, whether it's a treatment program, whatever, right? There's a bunch of different ways that people can benefit from things external to them, but sort of remind them help is available, but it's likely to be, you might need to lean on something for a period of time to support your recovery.
Yeah. So let me go back to sort of the starting of someone's issues around substance, and what in your experience might be some of the most frequent causes for somebody to start substance use? Curiosity of experimenting, home situation, what does that spectrum look like? And if you, any way that you're leaning on assessing what sort of starts the cycle for folks?
There's so many different drivers, but the way that I think about it is substance use is a solution for somebody. It solves their boredom. It helps them fit in. It helps calm their anxiety. It helps them forget about whatever, and that is deeply individual, right? And it's almost like every snowflake is different. Every story is different. But the final common denominator is people using substances for a reason. You know what I mean? And sometimes the reason it helps me feel good, helps me. I was curious about whatever, right? Like everyone's got their own reasons, but it's a solution. And then when we comes time to diagnose the disease of addiction and diagnose a substance use disorder, that solution has become itself a problem. right? So that means recovery is, yes, like helping people address the substance use that is causing problems, but then it also means going a layer deeper. What are the drivers? Like, what were the drivers of using in the first place? What problems did this solve, and how can we come up with solutions to those problems?
Xenia?
I as well. A lot of people say, no, it's okay. It's okay. I know. I'll just stop now. I'll just stop now.
Right.
Well, you're still going to need to you still need to find relief, whatever it is, right?
Mm-hmm.
So we need to learn about new ways of getting the same relief so then that you can actually have a choice to have a different coping skill. But if you don't know what you're trying to relieve and you just say, I'm just going to stop relieving it, you're ultimately doomed to return and continue in the pattern, right? So acknowledging like, what is that driver? Is it, especially for women, weight loss is a big thing, right? Weight loss is a big thing driver for substance use. And that doesn't make sense to a lot of people, but to some women, that makes a whole lot of sense, right? It's the easiest way to lose weight, losing energy, more fatigue. Like there's a lot of drivers that will contribute to someone continuing to misuse the drug, right? Whatever the substance is, whether it be sugar or whether it be coffee or whether it be, like, we see it all, and having similar medical conditions evolve from whatever the relief engine is what I call it, the relief engine is causing. So the more that we talk about not focusing on the substance use and talking about what's really going on for them, and I have the time to sit down and listen to that, I think that causes a lot more connection and healing than just stop.
Mm-hmm. Mm-hmm. So something that got mentioned earlier, which I thought might raise some questions, and it did, was that incarceration is one of the risk factors for overdose. So why is that? And maybe you could explain that it's, for folks to whom that might seem counterintuitive, if you're locked up, how could you be using?
Well, the really direct answer is when people are locked up, their ability to use substances is interrupted. Let me be clear about what I'm saying here. People don't access drugs in custody the same way they access drugs on the street. Drugs are available in custody. I can't think of any jail or prison where there aren't drugs, but it's not the same drug sold the same way, right? And so people's use is intermittent. So what happens is that people lose their tolerance. And the classic example of people that die are either people that use things in custody and they don't know what they're using, right? So they were used to using methamphetamine, they were given a dose of fentanyl, they don't have any opioid tolerance, and they die in custody. So that's one example. And there are overdoses in virtually every carceral setting, but that's not the big number. The big number comes when people are released. Right. So then people are released, they go back to the same people, places, and things that they were before they were incarcerated, and they use the same amounts that they were using with their incarcerated without recognizing that they've lost their tolerance. So putting somebody in custody, and like I'll just sort of say, it just makes everything worse, right? We are always better off working with people in the community because custody interrupts their connection to their care environment, to their housing, to their social supports, to their public benefits, to healthcare, and now they're increased risk of death. Like it just makes everything worse.
Yeah. Xenia, what do you want to add to that thinking?
Ditto. And the other pieces too is the part that unfortunately incarceration, especially for people on Medicaid, is a necessary part because there's not access to a locked access a level of care. So for some people like me, in my experience, like I needed that locked stay, but I never met criteria for a hold, right? So now there's a lot of movement towards getting that level of care going. Hopefully we'll see it in my lifetime. But there are people that get past that point of agency that need that locked stay to stabilize. So if I hear what Brian is saying, and this is where harm reduction comes in, right? I'd rather work with somebody that's maybe continuing to use and wants to make different choices day to day to day to day, and they lessen the risk of overdose, whether instead of taking a break, you learn nothing, and then you come out to do exactly the same thing, and that's where you put yourself more at risk. Where, like I shared in my experience, like, if I return to use, or, I came out of remission and I, programs back then said, well, once you use, you're discharged. Once you use, you're discharged. Well, why not work with me, right? If the harm reduction model is really important to me, because I'd rather work with somebody that's continuing to use, trying to make changes on a day-to-day basis, than because they're trying to learn. So incarceration, sometimes you don't learn more, you learn less.
Yeah, very good point. So just a couple of comments from the audience. One person here says that they have bridge programs at both of their hospitals, and it's amazing. So yay. And if anybody else wants to write in their experience with bridge, I'd love to see that, and I'll try to call that out as well. So this is a very interesting question. Once an individual is in remission, is it possible for them to have a new relationship with substances that doesn't constitute a return to symptoms? And meaning that is it possible to not be meeting the criteria for active disorder? So any thoughts about that?
Yeah. So the short answer is yes. Right. There are people that meet an SUD, according to the DSM-5, those 11 criteria I had a slide about. It's possible that there's people who meet the criteria, go to treatment, and then their relationship with their substance is not abstinence, but no longer meet that criteria. That is a known phenomenon. I'll also say the healthiest, no, correction. Let me rephrase that. The safest thing you could do is not use substances, right? It is always riskier to use than not use. That is just sort of a truism. And what I've seen, because I mentioned substance use is a solution for people, right? If somebody goes back to using substances and they haven't addressed the underlying driver of why they're using in the first place, then I have no expectation that their use of the substance will look any different than it was before. You know what I mean? Like, yeah, you can white knuckle your way and abstinent, but if you haven't actually addressed the underlying driver, but there are people who do. And there's a comment in the Q&A on trauma, right? I talk about adverse childhood experiences. We'll sort of talk about like trauma can be tremendously injurious, right? To your nervous system, to your psyche. And trauma, if you think of it as an injury, people recover from it, right? And there are people that might, have a non-abstinent relation to substance use, but if the trauma isn't driving the disordered substance use, they may return to use and not. But I sort of am cautious when I talk to patients because I have some folks that they just want to go back to using. And I say, well, hold on. There's some work that I think you need to do first before you've decided that you're in the category of people that are going to yeah. And I don't know. Is that a UFI comment? I've had folks that really test that, like they return to use and it's not going well, and you're like, okay, you know what I mean? Like you're just like, okay, yeah, how many times are we going to try this before we might need to come up with a different strategy? But there are people who can return to use, particularly when the driver of their disordered substance use is sort of understood and addressed.
I agree. I have a lot of friends that, I happen to, through trial and error, find out that I'm the one that needs to be completely abstinent from everything. And I've tried all the avenues of saying, well, this one didn't cause me a problem, so I'll try this, right? A lot of people are experimenting, kratom and spice and this. I didn't have a problem with that. It's readily available and it makes me feel better. Great. And then a few months later, they're like, I'm in withdrawal. I'm in withdrawal and I need help. So there are people that have seen, hey, they stop using meth and they stop having problems, but they continue to smoke and smoke cannabis and drink. But are they meeting criteria? Because the criteria is based on distress. Is it causing a distress in their life, right? And so I love that there's different levels. I love that there's severe and mild and moderate, and that it's not substance specific, right? It's not an all or nothing 100% abstinence. Because there is that piece that, hey, if you did 5 years of trauma recovery, you probably have a lot more coping skills that, here and there or socially or occasionally, it's still okay. But then there is the people that are far extreme and severe. We have t-shirts that say sicker than most, right?
Mm.
And some people are sicker than most that can't have not one abstinent, not one substance, right? And they have to be mindful about medication because the brain doesn't know the difference between a medication or a prescription, uh, illicit or prescription. So there are those. So there's subsets in everything. Who am I meeting you in the emergency department to tell you you need to be 100% abstinent off of everything, right? I can't do that. I can tell you, well, you can go out and try some controlled use and see how that goes. And that's where you get the complete buy-in when they've seen the evidence for themselves in their own lives, and then they learn the more they're aware of what's really going on with them. And it's no longer about what we're telling them. They have experienced it and they know that it's real for themselves. And that's where you really get the complete buy-in and the move and the stage of change because they can see it for themselves.
Yeah. Okay. So this should provoke some interesting discussion. Is the care court model an appropriate intervention for youth with substance use disorder?
So, for those that haven't heard of it, there is a state initiative called Care Court that was established in the CARE Act, which is for adults who have chronic psychotic disorders. So, schizophrenia, schizoaffective disorder statute was recently amended to include bipolar disorder. It does not include substance use disorders on their own, right? Now, there's lots of people with bipolar disorder, schizophrenia, schizoaffective disorders that also have SUDs, right? But and having SUD does not make you ineligible for care court. And what the court does is put together a care plan that holds the county accountable for delivering a set of services to somebody in care court. And it's really designed for people that have very little insight into the fact that they need assistance. So this sort of provides an emphasis on court. But what care court doesn't is like then put people in custody if they don't follow the care plan, right? What it does is essentially emphasize the county. This is what the court expects somebody to do. For youth, my experience is that youth typically have systems around them, whether it's the juvenile justice system, the foster care system, or other child welfare system, or families. And oftentimes those systems kind of serve a similar purpose, which is like these are expectations for various privileges that you as a youth may or may not have. So I don't think, so care court was like a pretty specific thing for adults with chronic psychotic illnesses. And I don't know that like court mandated care plan would be necessary for youth where you oftentimes are using other system drivers. That being said, like one could envision a care court expanded to include SUDs. One could envision a care court expanded to include youth. Like that is certainly possible. But what I would not do is turn to the way care court is kind of currently operationalized and say, aha, that's just a thing. Like building an extra layer of like court mandate. What I do think though is how do we work with our DCFS system, child welfare system, foster care system, juvenile justice system, like child health care. Like how do we work within the context of youth's lives to make treatment services more accessible and available? That's my answer.
Xenia, you have thoughts on that?
I have a lot of thoughts on how to help youth. Because I still find that when I'm connecting youth to programs, it's still an all or nothing abstinence. And I think for youth, it needs to be very far on the other end of the spectrum. And any disruption in their social life, like pulling them away, going to treatment, it really counter affects anything that we're trying to do. So that's my only issue with youth. Like if we go to care court, it's going to be a lot of mandated stuff. It's going to be pulling them away from anything that they feel comfortable connected to. And that's only going to work in the opposite direction. Extreme harm reduction, extreme unconditional acceptance, for me, is my opinion, that would have probably helped me as a youth instead of this all or nothing, complete abstinence or, and you're not accepted unless you're fitting into a box, especially when they're in the stage of development of trying to just discover and kind of mold their identity. There's no boxes there. So reaching out to them and connecting them, and they are so much more informed than any other generation before. So giving them also that space and respect to say that they do have their own agency and they are able to make those choices. And education and connection would be, I mean, my best work for youth.
Mm-hmm. Mm-hmm. So this question is going to get a little bit thorny because we're going to have to parse through some stuff, but I think it's a good point to bring up. If only 19% of people receive treatment, then most people in recovery get there without treatment. We understand that treatment makes a very difficult pathway easier. Is there a way to help people realize that they can recover on their own and that they aren't doomed to stay in addiction if they can't get effective treatment, while at the same time continuing to promote treatment and supportive services?
I think I'm trying to remember the article. It was a Wilson Compton study where they looked at the rates of spontaneous remission. So that 75% figure is a lifetime figure. So while it's true that only 19% of people at a point in time receive treatment, more people than not actually do receive treatment, right? Just to be clear, like spontaneous recovery is rarer than treatment-assisted recovery. And so again, those are different, 75% is over the course of someone's lifetime, whereas NISDA is any given moment, right? At any given moment. And so what I think about is that 81% that aren't in treatment, they might be in treatment later, right? They may not be ready for it right now. Now, I'm an addiction psychiatrist. I'm in the business of providing treatment. So I like if I'm ever having a conversation with somebody, I'm almost never talking about, and you don't need to go to treatment, like by virtue of us talking, where like I'm trying to establish a treatment relationship. You know what I mean? Like, so that tends to be my frame. But it is a finding that oftentimes the drivers of substance use, whatever it is, resolves, right? Whatever the traumatic relationship is, whatever the psychosocial stressor is, whatever the driver of substance use was, can resolve. And SUD can spontaneously resolve. But like I don't know. There's a part of this that's bothering me a little bit, which is it's sort of like, well, treatment isn't accessible, so what are you going to do? I'm like, no, we can make treatment accessible. Like I sort of think you can make treatment accessible, and that is where I'm focusing my time and attention. So I did put in the chat, I like counting as something called the Reaching the 95% program. Exactly focus on that. How do we make treatment accessible, right? Because if we really had treatment on demand, hospital care, residential care, high intensity outpatient, like imagine what the world would be like if people could get care within the context of their lives whenever they needed it. Like that's the world that I want to build.
Zenia?
I think the 19% is a flawed data. 19% is maybe tracking the treatment that we're talking about. They're not talking about peer support. They're not talking about, so there's a lot of more people that are receiving, like, what if the 12-step community or the smart recovery community, the Dharma punks, like if all of those people that engage in those types of services were added into that 19%, that it wouldn't be 19%. That'd be such a higher number. If we're only tracking commercial or conventional treatment that has a provider that's connected to some kind of number, then I think the number is really low. So, and so that's how the data plays, right? If like it says, okay, 1% of the people that have an SUD actually, were seeking and couldn't get it, but that 1% number equals how many people? If that number, I think it's close to 500,000 people, is that 1%, then can we focus on those 500,000 people that ask for help? Can they get help? So I see how the data will play out, and it'll show like, oh yeah, 95% of people don't even want help, or they didn't seek help. But did they really? Did they go to a meeting? Did they go to celebrate recovery at church? Like none of that data is tracked. And I think that number needs to be also included in that treatment number.
Yeah, there's somebody who wrote in and said, I achieved remission without going to treatment, but that doesn't mean I did it without support.
Right.
Exactly.
That's a great point.
Yeah, that's exactly what you're saying. So here's a thought for you. Is having an addictive personality a myth?
I wouldn't describe it as a personality. We know that there are genetic vulnerabilities and personality factors and environmental factors, but like addictive personality just sort of makes it sound like that's like a character thing, and there are much more fundamental drivers behind substance use than like the structure of someone's personality.
Yeah.
I think the addictive personality thing came from, well, I'm not talking about drugs, right? But if I really like base jumping and I get a really big rush off of that, and I work
Mm.
two extra jobs so I can have enough money to go base jumping or traveling or something, and they say, oh, that's my addictive personality. It's really not. It's I'm looking for something that makes me feel better, and it do I meet the distress criteria of an SUD with it? It could be possible, right? We see that in shopping, we see that in gambling, we see that in all kinds of behavioral addictions, but because it's not substances, then they call it a personality.
Yeah. Let's pivot a little bit and talk about what kinds of resources are there and work for youth. I know we didn't really talk about that a lot in the big body of what you were addressing so far, but maybe you could spend a few minutes thinking about what needs to be different for youth. How are youth today different in how they present? How how much is available to them that wasn't available to people that are in older cohorts, or what isn't available to them?
Yeah, I mean, youth vaping is so much more common than youth smoking. Folks that might have been familiar with people sort of smoking in high school may underappreciate the degree to which like youth vaping has exploded and that youth smoking is pretty rare now, interestingly. And I'd say the other big shift is the cannabis that's used now is actually much stronger in its THC potency. Fentanyl is so much stronger than heroin or prescription opioids. And so like kids may go buy a pill and with sort of the like if somebody had sort of slipped a tablet of oxycodone in the late 90s out of a medicine cabinet, more likely than not, they would have like fallen asleep and woken up and been like, oh, okay, whereas now with fentanyl, I mean, we see youth overdoses and this whole report, I can't remember who wrote it, but there's a whole report on like what we know around youth overdoses would have gone up during the course of the overdose crisis, particularly including the fentanyl part. And then methamphetamine we use now, like it's just really, so like the substances have gotten stronger, the overdose risks have gone up. And the stuff that like folks may have sort of gotten away with without necessarily having like overdosed or have terrible consequences the substances are therefore less forgiving. I actually think that there's a lot of investments that are needed in early childhood development and particularly family supports, in school supports. And like we're in a health department. We do a number of like prevention programming, but I'd like to do 10 times as much as we have the funding to do. You know what I mean? Like there is a need across the board for investments in youth. There are a whole number of programs, right? And Medi-Cal has this EPSDT, which is like early prevention screening and treatment. There's another like acronym in there, right? Where like youth can access treatment systems, but we haven't necessarily built systems that are super responsive and accessible to youth. And um, and treating youth is so much less around treating youth, although youth definitely benefit from treatment. But it's also like youth that are using substances are using substances in a system with siblings, peers, parents, or guardians, or what, you know what I mean? And it's like those systems are also interventions on a given youth to make sure that people can like develop and support healthy emotional development. And like that's not been a huge focus. So that those are all like interventions that I would say is like the substances are getting less forgiving, and we have deep needs to invest in healthy youth development, so that people kind of don't need to use substances in the first place.
Danielle?
Youth have access to everything, but as a Brene Brown fan, the what is missing and what we've lost with technology is connection.
Mm-hmm.
Where why is Stranger Things so famous, right? And did people really hang out like that at night at people's houses and learn different family systems and learn to socialize, all these social things that we lost, and they were just worsened with the pandemic that we isolated so much. So I mean, the answer to me is like, I must say, more connection. Like, I know when I started getting into trouble as a youth, I still talk to the person that became my mentor. Like, I'm not going to say how old I am, but I still talk to him. The person that I met when I was 14, and he like noticed me and saw me and acknowledged me and just kept contact with me. Like, those are one of the most important people in my life. That no matter what I went through, from the time I was 14, I had this constant connection to someone that had unconditional acceptance for me. And so those are the nugget people that I remember as being the most impactful. The people that were there, and they understood and they accepted me. So I think the answer to that, before I start tearing up even more, is connection.
Yeah.
Connection and care. And, yeah, we've progressed in so many areas, but that also means that we've lost that. We lost that social peace and feeling of belonging and valuing life where that we didn't have before. And I also, when I talk to our youth, I tell them, in my time, experimenting was fun. And if we didn't like this drug, we moved on to the next. And now, like Brian was saying, like now it's like you guys experiment and you could die. That's not even fair. Like you guys
Yeah.
are losing this rite of passage that I
Right.
got to enjoy. But I want you to know that it's okay with what you're doing. You're not doing anything out of the norm, but we really want to protect you and your friends because you guys are all really important to us. So here's some Narcan, here's some fentanyl test strips. I can't stop you from using, but I just want you to live and survive through it.
Yeah. So I'm going to ask as the sort of final wrap-up question, how can we support families and friends of loved ones who struggle with substance use disorder?
There's actually a whole sort of process called the community reinforcement and family training kind of engagement that can help families. Because what I see with friends and families impacted by people in their lives using substances, they just feel helpless, and they just want their loved one to do what they want them to do, right? Whether it's abstain or go to treatment or whatever. So first of all, sort of attending to people's own well-being, which is sort of counterintuitive. I'm not the patient, they're the patient, they need the help. But actually, like oftentimes with the amount of distress caused by that, people need their own help and support. And then to be very mindful over wanting to maintain a relationship with their loved one, right? It's generally not helpful to like seesaw communication, but to set the parameters for that contingent, like there being some contingency. So for example, like, no, I'm not going to give you money to go use drugs. If that's, depending on the nature of somebody's relationship, right? That might be a line for you. Or no, you can't be, living in my household if you do X, Y, or Z behaviors, right? Those are all examples where you're allowed to set boundaries, but say, hey, like, I love you, I care about you. We'll go out for coffee together. You know what I mean? Like you can still maintain a relationship while trying to also maintain your sanity. And I would highlight craft as a really helpful framework for navigating that.
Xenia?
I myself, with patients that come in and that have family that come in with them, I really turn my focus to the family.
Yeah.
Because I tell them, regardless of what happens today, regardless of what happens tomorrow, you need to be okay. And you need to be okay and learn about his, and the patient would say, I don't like the way that they're doing this. And the message is that they love you and they care about you and they're doing the best they can with what they're feeling, right? A lot of ways that families want to help are not actually helpful. So I really focus on the family member and, you want to learn how you can be best helpful to your loved one, but you need to stay healthy yourself first and about the self-preservation for them too. And because a lot of times I don't know what to do, so I'm bringing them here for you to fix them, right? And it's like we're probably not going to be able to fix them in a 30-minute time span. But what I can do is help you be better, better helping to them, right? Because that's a lot of the friction. The person that is ill is saying, I don't like the way that they're helping me, and the family member is saying, I'm doing everything that I can to help. So I'm kind of finding out how that's going to work and having those conversations of what kind of help is really helpful is really important for the family.
Right. Well, I think that's all been very, very thoughtful, and we really appreciate all of the wisdom and experiences that you've brought to this table. And I think just as a last little thought, Xenia, tell us a little bit about why you made this your career. And the same thing for Brian.
Mhm.
Sandy, you get to go first.
Oh, well, I initially wanted to start helping people because I used to sit in treatment and watch other people that don't speak English be mandated to treatment and have no providers speaking their language. And they got pushed through the program and they have recidivism, and they say, oh, see, those people, they don't really want help. There was no one that spoke their language the whole 90 days, and you wanted them to learn how to stay clean. Like that, it made no sense to me. So my first initial driver was to be in my community, be that bilingual counselor to give the people from my community a chance. I and then it just started morphing into more, and I just saw how much stigma really impacted people um, not seeking treatment, and or even when they did try, just the disappointment over and over again of having to call a number and be on a wait list, and just how despairing that is, and how how awful that feels, and how that unworthiness is really, 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 really hard to come back from. So anytime that we can say, yes, I can get you somewhere, is one time that we don't have to make that person feel less than human.
Thank you. Thank you.
When I graduated from high school, I grew up in LA in a performing arts high school with lots of folks who use substances. And I got sort of interested in how substances work, actually, like in the biology of it. So, like, I worked in a lab in college and I studied methamphetamine and sort of learned a lot about receptors. And enough so that I learned that I did not want to be a scientist studying how drugs work on receptors. Like I feel like I like kind of got that out of my system. And then I learned about this field of addiction medicine, which seemed like a really interesting combination of like learning how to take care of people, to address, kind of like a social medical issue, like at the intersection of kind of like social determinants and like, traumatic experiences and genetics, right? Like that seemed to be a really interesting body of work to sort of command. And then, and I just saw there was this huge difference between the science or what we know worked and how we can help people and what was being delivered. And like that was a really interesting problem for me to solve. So that's kind of I want to go to medical school to practice addiction medicine. That was my like, that's what kind of got me started. I've been pretty focused on that ever since.
Well, let me thank both of you for both opening all of your experience, bringing it to this group, but also really opening your hearts and letting everybody know that you really care about this issue, that it comes from someplace deep in both of you, and that there's so much to share. And I think just in creating the community of this call, this Zoom, hopefully a few people have felt that there's a little bit more hope there, a little bit more light at the end of the tunnel, and more things that we can do to make this a more caring and a more effective community. So just thank you for that. I want to just say one person here at the end said, this has been an excellent program, one of the best I've participated in. Thanks to all. So just saying that back to you, and also thanking everybody on the staff who really brought together a tremendous amount of material to make this thing happen. Please, let's just pull up the last two slides, if you don't mind. Yeah, we want you to join the overdose prevention movement. If you aren't already getting it, sign up at nopn.org, and we'll send you links to all these webinars and connections to the previous ones we've done and whatever tools that you might find useful. But please suggest to us what it is that you need to know more about, because this is how we build this program. We want to be moving on your issues and your needs. The last slide, please. So just let us know. And to wrap it all up, thank you so much for being a part of this conversation and sticking it out with us. This was a long webinar and it's hard to sit through them, but we appreciate that you're here with us. Thank you, and we'll see you next time.